back to our podcast, Hypermobility Haven, with me, Amanda Carey.
And me, Holly Graham.
Both final year BSc physiotherapy students at the University of Brighton.
As we have previously mentioned, none of the information you'll hear in this podcast is professional advice, more just ideas and what we've learned about these conditions as student physiotherapists. If you want any further information about anything we've discussed, please contact your GP or your primary caregiver. Today we're going to be discussing a multidisciplinary team around chronic conditions, guidelines and features that might be involved. So to start off with the guidelines, the NICE guidelines, which are the standardised guidelines that most clinicians will go to, refer to management for hypermobility and red flags, but there's not really much there on the management techniques and how it's such a spectrum of disorders. Like we've already discussed, it's different for everybody and it's quite hard to pinpoint this is the exact management that you would use. So for example, pain management for hypermobile EDS, people might present with generalised pain, fatigues, headaches, gastrointestinal pains, trabeculomandibular joint pain. I might have absolutely butchered that. I do apologise.
Temporomandibular joint. So
Thank you. That's your
TMJ.
jaw.
Yeah,
your TMJ joint. So much easier. And that's in your jaw. And then things like vulvodynia and, I'm going to butcher this again, you're going to have to help me,
Dysmenorrhea.
Dysmenorrhea. Sorry, reading is not my strong point. And a lot of these things aren't commonly spoken about. So especially the dysmenorrhea, so that is painful menstrual cramps, sort of like pain, and vulvodynia. We're going to do a bit more of a deep dive into the pelvic floor correlation with chronic conditions that we've been looking into, as we feel they're very relevant topics that don't genuinely get spoken about.
Indeed, and also they don't get spoken about for the general population, let alone if you have a chronic long-term illness, which leaves you at a greater disadvantage and risk of having, unfortunately, symptoms relating to these disorders. So we're also going to be kind of talking a little bit about pain, because that tends to come into the features or the symptoms of the conditions, and also trying to look at techniques to minimise the sensation of pain, which could, even just through relaxation techniques. So we'll be looking at management strategies for chronic pain, for example, including physical therapy, medications, as well as medical equipment. Joe is a specialist on the subject of orthotics, so thinking about compressive garments, bracing, and even thinking about cushions when it comes to supporting the body when you're doing physical activity, or when you're at rest, or when you're working. You might be working from a computer, that kind of thing. So these are all strategies that can be used and don't necessarily require, unless you're looking at like a first instance of having a referral, don't necessarily require ongoing care. So orthotics wise, compression garments, you can be referred to an orthotist, but you have to do that through the GP. So as student physiotherapists, we are very interested in the psychosocial model. So generally historically we kind of look more from a biomedical perspective, but obviously now it's much more recognised that the brain-body connection, also looking at nutrition, which relates of course to gut supports, as well as mental health, and even social support, and creating a common language with which to communicate your needs, not only to family and friends, but also to professionals. So these sorts of ways of looking at management of your long-term condition should hold you in good stead and put you in contact with all the right professionals. So we look at, in terms of physical rehabilitation, we look at core stabilising, joint stabilising, and proprioception. Proprioception is, you're not sure of that word, is to do with an awareness of where your body is in space, and this is something that typically is found to be lacking in people who have hypermobility disorders. However, these enhance exercise, particularly in people with hypermobility, but in the general population. We also look at manual therapy for overactive muscles, joint mobilization, which might incorporate active muscle release. If you go for a sports massage, they'll do that, but for someone with hypermobility, that's probably a bit of a strong type of massage, so you might look at a more gentle approach. Trunk stability, so Pilates can be good for that, other core strengthening programs. Posture re-education, really important, because a lot of the time people with hypermobility spectrum disorder and EDS suffer with a lot of, I call it like a coat hanger syndrome, with the neck and the shoulders being involved. There's a lot of tension. Can also possibly be a compensatory pattern, so they're holding tension there because they struggle to find stability, because of course that's mostly connective tissue around the neck area. So posture re-education is especially important, and also joint awareness using biofeedback, because in the absence of, for example, proprioception, natural proprioception, we might use different methods.
I also think, linking back to the coat hanger that you said around the head and the neck and shoulder pain as well, especially because people are aware that a lot goes on in your head and neck, for example, like your brain and your nervous system. So it could almost be a sense of they're scared, they know their head is heavy. They could be scared that if something happens to their head or their neck, that it could be much more detrimental than, say, you've hurt your shoulder or your knee, because of all the horror stories that you hear on the news about someone falling over and hitting their head, or being something happening to their neck and it's caused things like paralysis or further nerve pain, that they're like, oh my goodness, I already have all of this going on, and just like tensing everything around them, which could in turn cause more pain. And I think with pain, when someone asks you to score it from 1 to 10, it's very important that you give concepts to go along with this. So, for example, my idea of a 6 out of 10 in pain is probably very different to Amanda's idea of a 6 out of 10 in pain, purely out of our own life experiences and things that we're comparing against. So, say you went to a clinician and was like, oh, score your shoulder pain on a scale out of 10, for example, and you said a 5, they might just think, oh, a 5's nothing. But if you said, oh, my shoulder pain is a 5, but a 10 out of 10 for me is being pinned in a multi-car pile-up, they'll have more idea of, oh, okay, they're in a significant amount of pain here. What can we do around this?
Definitely. Also, actually, what I sometimes think is more useful in a scale is, rather than thinking what's your worst level of pain, think of something similar. So obviously, if someone had been involved in a horrific car accident, or for example, if you've ever given birth, those sorts of, that level of pain and those character of that pain is probably very different from if you're exercising. It's not going to be the same type of pain that you're going to experience, and it's not going to be the same sensations that you'd experience.
No, yeah,
so you need to
absolutely.
identify something similar. Where have I don't know, maybe caused an injury when I was moving? At what point, what did it feel like? Can I try and remember what it felt like just before I got injured?
Mm-hmm.
What was the character of the pain? And on a scale based on that, could you create a scale that was actually more measurable and more specific to you?
Yes. I think a big part of that as well is making sure that yourself and whoever has asked for this scale, it could be a physiotherapist, it could be a doctor, it could be an occupational therapist, it could be anyone, make sure that you're on the same page and you both know exactly where you are in that spectrum. And as well, make sure that they know what type of pain it is. So is it a shooting pain? Is it a cramping pain? Is it a joint pain? Is it a muscle ache pain? Because different pains could mean different things. If you was with a physiotherapist and you was working on building up strength for a range and you think, oh, this hurts, it could be that it's not right for you, or it could also be that that muscle is now working within its full range and it's a new experience for your body to understand. So if you then stop exercising and your pain subsides within a minute or two, maybe that is just a pain that comes along with exercise in your muscles that will help you build that strength and stability over time to help with joint weakness and instability.
Yeah, because we know that generally people with hypermobility have a sort of low exercise tolerance, but we also know that there's different processes involved in pain, including central sensitization. So it could be that someone is basically hypersensitized to pain. So any kind of change, any sensation might trigger a previous experience of pain. And that's not necessarily because the thing that they're experiencing in that moment is causing harm. And I think that's what you're basically trying to say. So we need to maybe spend that time again, as we talked about in the last episode, the first few sessions that you plan to exercise, just focus on the relaxation, tune into your body, ask questions about yourself, about how you're feeling.
Definitely, yeah. It's one of Joe's pacing strategies, but taking a micro break every once and again, even whilst you're exercising or moving or doing whatever, and thinking, okay, am I in pain? Is this a normal level of pain? Is this additional pain to what I'm used to? And how does it make me feel? What is the impact for me? And do I need to do anything or change anything about what I'm doing to affect this?
Also, actually, are there any other symptoms?
Yes.
So are you feeling dizzy, for example? Then probably that's not great. So maybe if you're standing up and you have POTS type symptoms, then perhaps you need to modify that exercise. Again, you may need the help of a physiotherapist or a Pilates or other movement instructor to do that for you, or you could possibly look it up yourself. But most exercises can be modified. Obviously, they're not going to they're not going to load the muscle in the same way if you're performing them in a different position, but the mechanics of the movement and the actual movement at that joint will still be pretty much the same. It's just that gravity will affect the muscles differently, obviously, in that different position.
Yeah, no, definitely. And it's especially important for those with connective tissue disorders that you use gravity to your advantage, so you can work against gravity, and that could even be enough resistance for you to start with, or you might not even be able to do that to begin with. Or then adding something, I don't know, you don't even need a weight. You can use a tin of beans from your kitchen cupboard, for example, to add a small load within that range, and then you can gradually build it up that way, because it's been known that people with hypermobility and similar disorders, it takes them longer to build up strength. So they'll still get there, they'll still be able to build up this strength. It just takes longer, more perseverance, more practice to get there and to have strength throughout that whole range, which I think is really important, that people understand that and don't expect for things to change overnight and things like pain to go away straight away as soon as you start something, because it takes time and understanding your body and what's really going on.
And also differentiating, which is very difficult, between pain and fatigue.
Yeah.
So if you're experiencing chronic fatigue, Dr. Jessica Eccles says it's very difficult to distinguish between, chronic fatigue and pain sometimes. And for a lot of people with these conditions, fatigue is the worst part, because it forces you to slow down and forces you to have to break movements up. So you're not necessarily even getting a full experience of that exercise or that movement, because you might have to break it down. But, bear in mind that for anyone, things will take time for you to reach that point where you're able to do something comfortably. So for any of us, even without long-term conditions, if I'm doing a new exercise sequence that's involving some very different training principles, I'm not great with balancing stuff, for example, compared to other core work, then I know that I'm going to have to take much longer to train myself with those new principles, because for me, that's an area that I need to take time with. It's not easy for anyone, is the point I'm trying to make.
It's not.
But there's definitely ways that you can make it easier. Again, we mentioned, but we're not going to go into detail, because, again, you can refer to Jo Southall and her resources and her expertise, but you can look at compression garments and so on when you're looking at helping with exercise. But she can give you more advice about that.
Another thing I've noticed about hypermobile population is that people tend to lean into this flexibility and take part in aesthetic sports such as dance, gymnastics, or take part in things like yoga, where they can really lean into this flexibility and think, oh, this is amazing, they're asking me to, I don't know, lift my leg right up to my head and I can contort my body into these amazing positions really easily with no concerns whatsoever, but you're not actually considering, do I have the strength within the range to actually hold my joint there, and am I just pulling it because I don't know any different and my joints can just do that, or am I doing it properly in a safe way that will benefit the joints and affect pain and proprioception, things like that. So I feel like a lot of people, especially in yoga classes, need that feedback a lot more of where are your limbs in a space, especially linking it back to this proprioception that we briefly touched on. Where are you within the space, and do you know how to control your movements and what you're doing? Because it's more about, for example, your leg might only be at 90 degrees instead of right at your head, but you can control it and you know exactly what your muscles are doing and how it's getting there instead of just flinging yourself around.
Definitely. Even something as simple as like downward facing dog. A lot of the time the emphasis is on pushing the feet to the floor or heels to the floor, but actually what tends to happen is that people tend to tilt their pelvis back again. So we teach a variation of that in my class, which is focusing on Pilates, but it's like a myofascial element. So we tend to bring the pelvis into more of a centered alignment. And then with that, what you're doing is you're kind of lengthening the hamstring more. So I say to people, it might not feel like you're achieving the same amount just because your heels aren't touching the floor, but actually when they do it, it feels better in their body because they feel the length in the hamstring. So I think sometimes we have these misconceptions about how we should be pushing, or directing the body. Even the terminology people use, I tend to say press rather than push. I don't tend to say push because it sounds really harsh and I don't want people to do a harsh movement. And that's not just people with hypermobility. This is literally anyone. So I'm very careful about the language I use. So try and find an instructor who uses nuanced language, who actually has, even if they don't have much knowledge in the area of your condition, that they're very careful about approaching people as an individual.
Yeah, and especially like focusing on technique. I think one of the big downsides of social media especially and the internet and looking things up is you see all of these amazing things online of yoga and dance and gymnastics, and that could just be the one take where they've done it, but their technique might be awful. They might not have actually done it correctly in the safest way possible, and then when people see this online and they try to replicate it, a lot of people, again, not just within the bendy society, so with hypermobility and hypermobile EDS, etc., that's where pain starts and they become more injured and they almost lose technique for aesthetics, which I think it needs to be flipped the other way round, really. It doesn't really matter how you look as long as you're doing it correctly and what feels good for your body.
Although, saying that, I would also add that often when people do things with a good alignment, it looks better.
No, yeah,
but
absolutely.
their perception of it is based on, as you're saying, a social media perspective where you stick your chest out, pull your shoulders back, for example. Now, that's not a good cue to give someone, particularly with hypermobility. However, we tend to have this idea in our head that that's how we should walk and stand. But an anatomical position for the arm is to be slightly in front of the shoulder. So, we're not doing ourselves any favours. I'm really good that you mentioned social media, Holly, because that brings me to our conversation we're going to have about pelvic floor and pelvic floor dysfunction. So one of the students I was speaking to recently about a dissertation topic which is on pelvic floor health, they brought up how in their gym female athletes were, sometimes had a bit of a wee when they were doing powerlifting. And they also mentioned that social media they felt was very much to blame for this, and that they felt it was promoting, and this was actually a guy saying this, that it was promoting, this negative attitude, particularly towards, female athletes who, because of the nature of our different anatomy around that area, there tends to be more of a leakage usually, especially due to stress. So that's stress incontinence, that's called. But these are also things that, hypermobile types can also suffer from. So we were going to talk in a bit of detail about that and also how people tend to not only ridicule these dysfunctions, but also, social media in particular, that they normalise dysfunction. So they tend to sort of say, oh, well, it's normal in, pregnant women, for example, or women in the postpartum period to suffer with this urinary incontinence, or even more elderly people, they tend to sort of associate it with. Whereas in actual fact, it can affect anyone. And really what we should be looking at with all of these conditions, or rather the features of a condition, is how we can try and prevent those things from happening. And that's through health promotion, which is one of the key areas that as physiotherapists, that's what we're going to be trying to do when we qualify, is trying to serve the community and promote health rather than normalising dysfunction.
Yeah, absolutely. And I think pelvic floor dysfunction is a really difficult topic for a lot of people, as it's not really spoken about, and people tend to hide it and just think, oh, it's normal, there's nothing that can be done about it. And actually seeing a pelvic floor physio, if you feel comfortable doing that, could actually really benefit you within 2, maybe 3 sessions already.
So there's lots of different ways that we can address the pelvic floor. So we're just going to kind of go back a little bit to what the different symptoms or different dysfunctions might be relating to the pelvic floor. So, for example, I'm not sure about the UK population, but 50% of the US population suffers with urinary incontinence. And in pelvic floor muscle training, the hypermobile population, for these people, dosage and the threshold are important. So at what point, we've already been talking about this, at what point should you stop and how frequently you should be doing the exercises. This is also relevant in pelvic floor training. In particular, in hypermobility spectrum disorder and hypermobile EDS, pelvic floor ligaments and muscles usually compensate for what other muscles aren't doing. Sound familiar? We've already talked about this with other muscles, and the pelvic floor is no different. So this results in hypertonicity, which is basically where the muscles are overactive, overstimulated. Not to say that they're strong as a result of that, but it creates a weakness. So, and this usually happens superficially in the closure of the vaginal opening, and also deeper in the bladder, rectum, and in the uterus.
I also think where you said, oh, this is a weakness, I think is a really nice point to mention. It's the same with any muscle. A muscle can be really tight, but a tight muscle doesn't necessarily mean a strong muscle. A strong muscle means that it can work through, as we've mentioned, its full range. So especially with people who have hypertonic pelvic floor, means they can really pull in their pelvic floor, which is great, but they can't relax it out. They can't relax it downwards, which then creates the problem, which can cause things like sexual dysfunction, bladder and bowel dysfunction, pain during intercourse, and many other symptoms like that.
Definitely. Yeah, the pain could be also localised, or it could be generalised, and again it could be referred to another part of the body, which we'll go into shortly. But just to go back to the point you made about the needing to relax the pelvic floor. So if you think about it with any muscle, the key to regaining full function of that muscle or that structure is to fully contract and then also be able to fully release. So you need to be able to have softness, strength, full control of that would be the ability to control that muscle through all of those ranges of movement. So an end range and a full range, and also every other range in between. And so a lot of the problems that people have are where they are required, let's say you're on the underground or you're on a long car journey and you can't hold your urine for that long, it was unexpected perhaps, and there's leakage. You know, it's partly because when you need to recruit those muscles, the strength isn't there, or the sensation of strength isn't there. And that's because you've been pulling those muscles in. That's what we mean by hypertonic. You've been actively pulling those muscles in, maybe without realising, or possibly because you've been told to do your Kegel exercises, for example, and people aren't really fully educated about pelvic floor health. And then it means that when you are required to use that strength, the strength isn't there, because to go into a full contraction, it has to be relaxed first. And that's the point that people kind of misunderstand about pelvic floor. So there was a fantastic episode about this on the Bendy Bodies podcast about pelvic floor interaction and other areas. That took place a few weeks ago, episode 127 with Emily Bohan. And she specifically works with pelvic floor as a physio. And so you could go to a pelvic floor physio, but it's quite hard to obviously get a referral. It might even be, due to health inequalities, that you don't necessarily have easy access to that service in your area, particularly if you live in a more remote area, or perhaps you might struggle with the more intimate element of that and might be worried about someone probing around that area. But the good thing is that what you need to know is that they don't have to necessarily be hands-on in that area, because there's also myofascial trigger points that could refer pain to that area. So they might release trigger points in the abdomen, for example. And also there is a deep connection to the lower back and the hip with pelvic floor. So that could include like a snapping hip syndrome, and that could be tightness in the buttocks. It might not be related to the pelvic floor, or it might be related, but you can release it through the more external muscle groups. And again, long-term pressure through the pelvic floor can, due to compensatory patterns, can reduce sort of proprioception and result in very unhealthy habits. So it's really good to kind of be aware of this.
Yeah, and I think that point that you mentioned is really important, because a lot of people will think, oh, I don't want, that's a bit too intimate for me. I don't really want someone probing around in that area. But actually, you can go and state this, and there's still ways that you can get help. And there's still ways, so like Amanda said, the fascia in the abdomen, or you can use the hips or the back or things like that. It's the same way that you can get referred pain, that there's trigger points that might help you strengthen your pelvic floor without it being too personal. And the stigma, I think, built around pelvic floor, and it's a conversation not a lot of people feel very comfortable with, which should start to be spoken about more, and people feel more comfortable realising, oh, okay, I do have a pelvic floor issue and it is something that I need to address.
Definitely. We also haven't even really spoken about how, I suppose, dysfunction can occur, particularly in, hypermobile populations. If we're looking at how, people with hypermobile tissue have more stretchy tissue, their bowels tend to have more stretch as well. This can result in increased resting tone, and then that can cause a feeling of urgency. Or it could be that they, as I've said before, maybe holding their pelvis in a very sort of stuck position to try to get more stability, and as a result of that they're engaging those muscles without really realizing they are, or they're unable to relax those muscles in the position that the pelvis is maintained in. And so some of this is about education, some of it's about posture management. Lying on the floor, actually for me, I would say is the best way of thinking about pelvic floor, partly because you're able to then bring your pelvis into a more centered alignment. A lot of the time people focus on pelvic floor sitting, but a lot of people have discomfort when they're sitting, and they're not able to sit on top of their sit bones and bring the pelvis into neutral, which means that the pelvic floor is actually stressed in parts of the pelvic floor. And so I would always suggest that you try either on your back, or if that's not comfortable, side lying with some pillows to sort of support you. And then you could just place your hands sort of around the pelvis and focus that way. And also pelvic floor fatigue can happen, obviously, as fatigue with any other part of the body. So holding stress in the pelvis can happen. Think about your emotional stresses in your life. Think about the stress buckets. Are you able to try and find a space to relax? And that will help as well.
No, yeah, definitely. You mentioned the stress bucket. I really like that concept of all of your stresses and worries and fears all build up into a big metaphorical bucket in your body, and finding ways that you can one by one release things out of this stress bucket will in turn help things like your pelvic floor, because it's not holding all of this tension, and it's allowing you to relax and gain back control over what's going on in your body.
Definitely, and giving you a space to to tune in to what feels normal, or what's your baseline, what is an easing factor, what aggravates symptoms. It's very difficult to identify those things if you're not in a relaxed state. I suppose the first key thing really is to kind of focus on relaxation techniques
Yes.
before you really start to kind of bring in all of these other interventions. You need to almost start, I'm not talking about meditation necessarily, I'm just literally talking about the ability to get comfortable, try and tune in. It might be, the breathing's a really good thing to tune into when you're relaxing. Some people benefit from music. Some of us, if you have neurodiversity, might find that really annoying and just distracting. So again, it's very individual, which is another reason why it's quite nice doing exercise remotely, because it means that you can, or don't necessarily have to have music on, or if you prefer, you can have whatever type of music that doesn't annoy you. So
yeah, it allows you to feel safe and comfortable in whatever you're doing, and it eliminates a lot of the external factors and anxieties and stresses that could build up on an activity that initially you think, oh, this is a pretty straightforward activity, but when you start to counter it, like to add in, oh, I've got to portray myself in this way, there's going to be other people there's going to be music, I've got to get there, maybe public transport, a lot of things can build up, and then all of a sudden that's your stress bucket building up very, very quickly, and finding out either strategies to help empty out that stress bucket or ways you can adapt activities so you still get the benefit for you, but you're doing it in a way that doesn't build up your stress bucket and makes it a lot easier and more effective for you to do that. Because then in turn you'll, I think, excel a lot more in whatever you're doing. If you're in a comfortable environment, you're as relaxed as can be, and you can fully focus on what you're doing, whether it's then or later on or whenever it is. You are allowing yourself that time that you need to relax, reset, and focus on what's to come next.
Actually, you've got me thinking, as I'm picturing, as you're talking about relaxing and using all this lovely language, I was thinking another thing is temperature regulation, which is another feature of hypermobility, but more specifically thinking about POTS and chronic fatigue, mast cell activation syndrome, things we're going to be talking about more in different episodes. But a lot of it is to do with temperature regulation, and people can get very hot or very cold. So again, you can regulate that in your own environment a lot easier than you can if you go somewhere else. I'm not saying that ruling out going to a class somewhere else, but these can be considerations. If it's something that puts you off exercising at all, there's definitely some kind of movement-based program out there for everyone. It's just a case of trying to work out all of the different component parts, putting it all together and making a package that kind of works for you, really, because the worst thing is doing something unrealistic, which might even be going to a group class, when, for example, you use mobility aids, you're relying on public transport, there's issues with public transport where you live, these sorts of things. Already you're starting from a false point where you're going to set yourself up for a fail. So you kind of need to bear that in mind, because otherwise you're going to just be disheartened probably when it doesn't work out. Whereas in actual fact, maybe just starting with something online might be a good way to go, and then gradually work up to going out if you want to after that. The other thing I was just going to mention about pelvic floor therapy is that it can help you work on delay techniques. So, for example, when you go to the toilet, you shouldn't be pushing. One of the common things I notice even with my children is I hear them and I'm thinking, you're not emptying your bladder. So I've taught them and I've said, you need to wait another moment when you think you're finished, and then more will, a little bit more will come out. And it sounds really weird, but most people kind of don't realise that, or they're in a rush, or, for the boys at school, it's unfortunate because there's all of this time pressure about going to school and not having enough time to go to the toilet, or having to hold it all day. And these are really, really negative associations people make with going to the toilet, and people aren't taking the time they need, unfortunately. But these are all things that can contribute to pelvic floor dysfunction, and also, trying to use intra-abdominal pressure when you empty your bowel instead of pushing. So if you're not sure what I mean, go away and think about it. So it should come from the diaphragm down, is kind of where it should come from. Which brings me to talking about the core can, which Emily Bohan was talking about in the Bendy Bodies podcast, because she talks about the diaphragm sitting at the top, the core muscles in the middle, and then at the bottom, pelvic floor. And so obviously the diaphragm, the breathing is going to have an effect. If you are holding your breath, if you are, I don't know, pushing your breath out too hard, or, you know, you're using maybe too shallow breath, these can all have an impact on the pelvic floor. And actually we want to create a good environment around diaphragm, the core and the pelvic floor, and try and think about it as a unit between those three components. So not just you can't just do core work without the other two, because it's not going to, you can do it, but it's not going to be fully beneficial.
Well, it links back to what we spoke about earlier as well, about how sometimes exercise or movement of any form needs to start with you figuring out how to breathe when you do things, because then it can help in so many different scenarios in your life, whether that's exercising your arms or exercising your pelvic floor or walking or whatever you're doing. It helps you realise how to breathe, in a sense. And also linking back to what you said earlier, Amanda, I think having time to reflect on what you've tried, what you really liked about it, what you didn't like about it, and what you would do differently next time is really important for, I think, most things in life, to be completely honest with you. Whether it is, I've tried a new intervention technique, or I've gone to a new exercise class, or I've tried something new at work. It's the same concept of, okay, we did it at school all the time. It's like, what went well and even better if, and applying that to daily life.
Definitely. I can't remember which podcast it was because I've listened to so many, Holly, but I'm going to laugh because you've done the same. But someone said, just because you've had a bad haircut doesn't mean you're never going to have your haircut again. Although actually at the moment I'm not having mine done because I keep having bad haircuts. And I don't want to waste money. But that's just because, I'm waiting. I'm not sure what I want. But the principle is sound. It's, a lot of people say, I hate Pilates, I hate this, I hate that. It really is so dependent on the teacher. The teacher has such a wealth of experience compared to another teacher. Some people have done a weekend qualification, believe it or not, and they call it Pilates. That's not really Pilates. There's so many nuances, and really you need to spend the time. And I know that a lot of people don't have time, but you need to make time. If this program's going to work for you, you're going to have to invest that time. So that first initial contact is looking into what the background of that person is, not necessarily where they've trained, but what's their ethos. Are they using language where they're talking about helping people, working with the individual, really taking pleasure in what they do and learning more? Are they open to learning? Because actually some teachers aren't. Some teachers kind of think, I've done my training now, that's it. And when you ask them, why are we doing it in this way? Because it's not really doing anything. Or, I get pain when that happens. If the teacher says, I don't know, that's how I've been trained, or, you'll get there in the end, or says some vague thing, maybe question their knowledge on that subject, because really they should be saying, actually, do you know what, I'm not sure. Or if they are sure, give you an answer, because we're all learning all the time. I've learned a lot of different things over the years, and what I do now is very different to what I did 15 years ago. But it's learning I've accrued. I haven't just replaced one thing for another completely. I've taken bits, from that learning as I've gone along.
Yeah, no, definitely. And obviously, when you first get a diagnosis, it's very overwhelming and it's a scary time and you don't really know what's going on or where to go or whatever. But this is where having your team comes into it. So having potentially your physiotherapist, your movement therapist, your occupational therapist, your GP, everyone on board, where you can say, I'm thinking about doing this, what do you think? Having someone else's, that sounds like a good idea, or, I know someone that can really help you with that. It almost takes some of the stress and the anxiety and the pressure off of you feeling alone in this situation, that actually you have your own little community and everyone understands. You have your universal, your similarity language, so you don't need to explain everything all the time, where you can you feel safe and you feel like you can ask a question. And a lot of people were scared of asking, is this a silly question, or am I just undermining you because you're the teacher and you know better? But actually they don't know your body. You need to ask. If you've got a question, is 9 times out of 10 a very valid question to the situation, And I think actually asking that question and putting yourself in that situation can sometimes really, really benefit you of this is the right situation for me or this isn't.
Definitely. It's interesting you say that, because actually in one of the things that sticks with me with some Pilates training I did was the tutor actually said to me the key was the feedback element. So we had a kind of standard way that we would deliver the class, and we'd focus on the breathing and things in a particular order, but the last point was feedback. So once you've got them to in the right alignment, you've explained the position, the posture, you've explained the exercise, they're doing the exercise, the next question is, where are you feeling it? Or on a scale of 1 to 10, where are you? Does it feel like there's mild discomfort in the muscle, for example, in the abdominal muscles? Yes, okay, great. If someone says, oh, actually, no, I'm getting a pain in my back, you go, oh, let me come around to have a look at you. Oh, that's because you're arching your back, or whatever it is, or maybe it's not obvious and they have to ask you some more questions. We don't automatically know. Sometimes, very occasionally, I've looked at someone, they've given me the explanation of what they're feeling, and I'm thinking, I really can't fathom why they're experiencing that. And it's, I am a bit stumped sometimes, but that's quite rare. So usually I welcome people asking, because I think, oh, so sorry, I completely forgot to mention, I don't know, something really silly to them about the load they're using or something like that, because I assumed they'd remembered from the week before. So and I say, that's my fault because I haven't reminded you that you need to focus on this weight and that the other weight isn't suitable for you, for example. So yeah, it's definitely a collaborative thing between the practitioner, and that can be a physio, an instructor, occupational therapist. And yeah, you just need to constantly ask questions and try to enjoy yourself, because otherwise you're not going to go back, and you're not going to do it. So that's the what I'd say. Yeah, the main thing is to choose something you enjoy, because if you don't enjoy it at all, then it's very difficult to carry on.
And especially with this type of chronic condition, because they are lifelong. So your management strategies, you need to enjoy them and incorporate them into your life, because they will be lifelong. It can't be, oh, I'll do a 6-week block of physiotherapy and then I'll be fixed, because that's unfortunately not how the nature of the condition works. It's finding something that you can fit into your life and that benefits you enough for you to keep doing it for maybe decades on end.
Definitely, and thinking about definitely being clear all the time about the outcome and what you're gaining. So each time you do that session, what have you gained from that? Because that's what will motivate you to do the next session. And as I say, both of us have said, don't be afraid to ask questions. The key really with hypermobility is to make sure that you develop your resistance slowly. So you're not adding too much weight. Even just using the weight of the arm initially can be enough, for example, in strength training. And also, as hypermobile bodies are sensitive to load, then even cardiovascularly, you might just go walking, and that might be enough in terms of cardio, just to start with if you're very deconditioned. So bear those things in mind. We are going to just about stop there, but next time we're going to be talking about POTS, and also we're going to be talking about mast cell activation syndrome. So we've got a lot more things to talk about, and obviously we can talk a little bit more about exercise and how you might manage that with other symptoms or other conditions.
Lovely. See you next time.
Bye.